colonoscopy. Want to thank Dallas Weston Galleria for hosting this. Please, let's put our cell phones on silent. I also want to remind everyone of the welcome reception being held on this side of the ballrooms, the Dallas side, at 5:30, and also our membership celebration tomorrow at 7 o'clock, right next to us at the Fort Worth Ballroom. Dr. Raju, we all know Dr. Raju. He really does need introduction. I will try to be worthy of something worthy of Dr. Raju. There he is. Dr. Raju got his MBBS from Andra Medical School. He is also a member of the Royal College of Physicians. Came here through residency at the Cleveland Clinic, fellowship in Iowa City at the University of Iowa Hospital System, and did his fellowship at where I did my internship at Beth Israel Deaconess Mentor. Doctor has more awards than I could possibly summarize during the 2 hours, but currently is John Stroline Distinguished Professor of Gastroenterology, Hepatology, and Nutrition at MD Anderson Center, also having faculty appointments at Kansas University Medical Center and UTMB. He always, for those of you who have not seen his video sessions, he always gives us a melange of beautiful cases that generate plenty of discussion, a little controversy, and certainly stimulate all of our thoughts and new approaches to do things. So Dr. Raju, the floor is yours. Thank you so much for doing this for us.
Chuck, thank you so much. I'm sorry that I couldn't be there in person. I have to say that I'm in what is called a house arrest. So I'm sorry about that. I want to thank the TSGE leadership, Dr. Lewis, and the governing board, Chuck, and Lisa for giving us this opportunity. And I also want to thank my panelists, Dr. Kim Isaacs, who is Professor of Medicine from University of North Carolina, Dr. Rupa Vemulepalli, Associate Professor of Medicine at UT Southwestern, Dallas, and my good friend, Dr. Jeffrey Lee from MD Anderson Cancer Center, and my good friend, Philip G. From the same institution. I really want to thank the panel. The goal is today, what I wanted to do is learn from this expert panel. How do they manage colonoscopy cases? Some of them you may think they are very basic. I put in basics to advanced to help not only practicing pathologists, but also keeping in mind the trainees. So let me share my screen. So I've selected about 10 cases. All of them are video based, and because the cases are too long and pretty heavy in terms of the PowerPoint, so I divided them into 3 PowerPoint slide sets, and we'll go with the first PowerPoint, and then I'll take a break and then change to the second PowerPoint and then the third PowerPoint. We have also included a poll EV so that we can have an audience response because we want to make it interactive, and I hope this worked for all of us. All right. So let us start this presentation. I think as a warm-up session, I would like to see whether this poll EV, what you need to do is go to your phone or iPad or your computer, go to either Safari or Google and put pollev.com /GSR 977. That will take you to the Pole EV station. And once you register there, you should see this map. And I would like to know where were you? I was thinking that I should put it, where do you practice in Texas? But there are two, and the map is too small. So I decided to go with Ubon. So it's interesting that we have people from Asia, Europe, Africa, US. So that's good. I think this is working. So as we go along, now that you got used to it, I'm going to give about 10-15 seconds for the poll to work. And once you have the poll, then we will have the panel discuss the case. That way, at least we keep it moving and be able to do at least the 10 cases. So this is a patient who was referred to me for endoscopic resection. And the patient, the biopsies were tubular adenomas. And let me play this video. And I want you to look at the video. And let me play it one more time. All right. So let us see. How do you manage this problem? Cold snare, hot snare, EMR, ESD, or you go for surgery? I want to share with you no one right answer. You know, it all depends upon where we practice, what we have learned, and there's always an opportunity for us to learn from the experts and then improve. All right. So about 2/3 felt a hot snare, and about 30% said yeah, EMR. Okay. Let me go back and let me ask one of the panelists to comment on what they think about this lesion. How about we start with Philip?
All right. Thank you, everyone. Thank you, Raju, for having me. Thank you to TSGE for the opportunity to sit on this panel. Like Raju, sorry I couldn't make it. I'm in a very similar situation as Raju, actually. But anyways, so for me, how I would approach this lesion, when I look at a pedunculated polyp, I look at two things. One is I look at how tall is the stalk. In other words, how much stalk is there? And the second is I look at how thick is the stalk. In other words, is this going to be a high likelihood that there's going to be lots of blood vessels and a high risk of bleeding when we resect this thing? So to me, this polyp looks like it's sitting on a pretty long stalk. So there's quite a bit of room to work with. And it seems moderately thick, but I wouldn't consider it like the thickest stalk that I've ever seen. And so my vote to fully disclose was hot snare.
Okay. So one thing is, I just, for the sake of audience and the panelists, just bear with me. For the sake of time, my videos were cut a little bit short. and I may not be doing justice by giving you a lot more information. And go to the next thing. This was actually a flat lesion, and it looked like it was a pedunculated polyp that was sitting on the side. That's probably why people thought it was a pedunculated polyp and they wanted to do a heart snare. I can understand that. So now that we try to inject, and with this injection, any other thoughts, Philip?
So this is a very good point, and that is that one of the things that I guess I did not mention is, when you evaluate a lesion that you think is pedunculated, it's also important to try to go around it to see if you can, I guess, play around with it, see if you can really kind of flip it back and forth. And I suspect, Raju, that in this case you probably tried to do. I noticed that you don't have a cap on your scope, actually. That would have made it easier to flip the lesion and try to determine if it was truly pedunculated or not. But my suspicion is you probably played around with it and then realized that it wasn't quite as pedunculated as you thought.
You're right. Yeah. And what do you think about the injection? Are you happy with the injection? Do you think it was a lifting like the way you want to see, or are there issues with the quality of the lift?
Yeah, so it's very interesting you bring up that point. Looking at the submucosal lift, it does not seem to lift the center very well. This seems to be a non-lifting center. It seems like it wants to lift all the surroundings but the polyp itself.
Right. And with that in mind, what's going on in your mind?
Something bad.
Okay.
So either, if this lesion has never been manipulated before, then the immediate concern is there a potential for invasive cancer? And actually, as you look more closely at the base of the limb, the surface feature starts, almost like in hindsight, starts looking a little bit more worrisome that there may be deeper invasion within the center of this polyp. In lesions that have been manipulated, for example, previously snared, previously hot biopsied, previously tattooed, this non-lifting could be potentially just from submucosal fibrosis. So it really depends on the case, depends on the history of this lesion.
Okay. I think with that, I want to go back to this video so that you could comment on the fold here and the fold here.
Right. So now, as you can see here, when you look at this fold, right, this area on the bottom, which you think is the pedunculated stalk, now when you kind of take another look at it, it looks like the folds are converging there. It looks like it's more than one fold that has been pulled in that area and is significantly thickened. The surface of it does not, looks a little bit more suspicious as well. Now, the surface of the polyp itself, it has, and I was kind of wondering about this when I first saw the video too, is how firm or how soft was that surface? You kind of get the sense that it may not be quite as polyp-like as it seems. Right.
That's good. That's good. One reason I wanted to bring this video, this is a quite old video. You don't see the cap like Philip mentioned. I've been using cap for maybe last 8-9 years. It's probably older than that. One of the things that you want to think about is have a polyp like this, right? You would have expected the polyp to be much more fuller. For some reason, this area is a little bit retracted, right? And the second one is this fold. You see this fold as it comes. This gave the impression to you all that this was a pedunculated polyp. I wish I'd shown a little more video to convince you that this was sessile initially, so that you didn't go in a different direction. But here, as you can see, there is fullness of the fold. Folds that reach to the polyp, with a little bit of tethering, or if there is a fullness of the fold, that should make you think whether there is a desmoplastic reaction or submucosal involvement from cancer. That is something to keep in mind. This is one of the features that you have to keep in mind and think about cancer when you see a polyp. There are other signs that are important, like if there's a lot of chicken skin type of appearance around it, and obviously if there's an ulceration or whatever. So, but this is an important take-home message I want you to keep in mind.
You hear me, Raju?
Yeah.
Yeah. So I wanted to mention that I was one of the 35% EMR side because number one, I couldn't see the other side of the polyp. Mm-hmm. And the second thing is I couldn't really delineate the margins well. So if I use a little bit of methylene blue and inject it, the margins become a little bit more distinct. Because when you perform ESD or EMR, you really want to have a clear lateral margin at least. So, and then the location of the polyp, where are you? And
ascending colon.
I'm sorry?
Ascending colon.
Yeah, so then you really want to have water non-dependent position before you embark on cutting,
right,
in case something happens.
Right, right, you're right. So let me ask, now that we talk about it and we get a feel that we are dealing with most likely cancer, and this proved to be a cancer, what will you do next? I don't know whether, I can't see whether Rupa or Kim are there. Want to chip in? Or?
So what would I do next? I'd panic. No, you know, it's tough. I don't do EMR in my practice, but we have two people that are very, very good with polyps, and they might be doing an EMR, but in the right colon, it would be a little bit dicier to do that. And so I would probably send it to one of my colleagues to take a look at, and if they felt that they could get a good lift on that and good margins, we'd go that route. If not, refer to surgery.
All right. Rupa?
Same thing, you know, I do not do like EMRs in my practice, but we have 3 to 4 of my colleagues who do it. The one thing is that, you know, in this video, you see that only one side of the margin is lifted, but we do not know that polyp can be lifted as a mushroom. And if it does, then it would be like a large EMR.
Right. So actually, this is, one second. So this is actually a case of cancer with a non-lifting sign. And the reason I brought this case is for the fellows to recognize not only the surface features of the polyp, but also what is surrounding the polyp, right? You know, if you have a thick fold, you should think about what is submucosal invasion. And the other thing is I wanted to share, which actually I've learned only recently, based on an article in Gastroenterology, where they talked about the metachronous spread of cancer by the way we actually have been practicing. You know, we typically take biopsies if you think it is cancer, and then we try to put a tattoo, right? Let me ask if that's what you normally do if you think it is cancer.
So yes, if I see a lesion that I think is cancer, I will tattoo the lesion and try to go several centimeters. And our surgeons like the upstream side of the lesion tattooed, and then again, biopsy if I don't think it's going to be something that an EMR is going to be attempted.
So what is the sequence that we normally do, right? Biopsy, tattoo. That's what I have done. Jeff, you want to make a comment?
Yeah, I don't like tattoo.
Okay.
So if I see tattoo around the, I always worry whether there is any fibrotic reaction that's caused by tattoo.
Right.
Tattoo, but in this case, looking at the size of the lesion, even though it's tethered at the center, I would still cut. And I would expect that I may have a perforation, some small target sign, and I would have endo clips ready, descending colon. If you are in the left side, you have a lot of options. You can use an Ovesco, and you can do endo suturing. But on the right side, you only have a couple of options. Clips, which is probably the only option, except now there's a new device, X-Tech, which we can talk about later. So I would just move the patient, make sure that the patient is in the non-water dependent position, and I would still cut it, anticipating there may be a target sign. And if I see it, it's usually very small. So I would close it and then perform injecting tattoo at least 3, 4, 5 centimeters, 5 centimeters below and 5 centimeters above, and make sure that you notify the surgeons where you inject the tattoo. And when you inject the tattoo, you can't really inject too much, because if it goes through the wall, it makes the peritoneum, ascending colon and descending, and the rectum are, depending on the location of the rectum, retroperitoneal. But if you inject so much into the intraperitoneal, the surgeons have a tough time too.
Right. So this is actually a T2 cancer. And what I decided was, when I saw the lesion, I felt that this is an advanced lesion. I did not resect, but we tattooed and sent the patient to. The point that I want to make here is, previously, even for this case, I used to take biopsies, right? It's a cancer, we thought it was cancer, we want to document it's cancer. And when you take biopsies, you take the biopsies from the most advanced looking area of the polyp, and then take a tattoo, do the tattoo. And then if there are any other polyps downstream, we try to clear them. Based on this gastro paper, after reading that, I changed my practice. And the reason I changed my practice was, they actually demonstrated that if you take biopsies from the cancer, the channel can get contaminated with cancer cells. And if you go back with your needle to do your tattoo, or you take a snare to remove any other polyps, they can be a source for metachronous lesions. It's not proven with many studies. It's just one study with an editorial. Based on that, this is what I've done. Changed my practice since that. If you want to clear all the polyps before you biopsy the cancer, and before you biopsy the cancer, tattoo, and then you biopsy at the end, so that there is no contamination of your channel and other instruments by going that reverse direction.
So,
I just wanted to say that.
I'm surprised that you didn't cut it, and I guess you're better than EUS, because if I get scared, if it looks like it's T2 or beyond, I would drop in a endoscopic ultrasound probe through the colon scope, therapeutic channel, and it takes about 2 or 3 minutes to be able to see whether it's involving the muscular propria layer or not. But being able to see that it's T2 without doing endoscopic ultrasound, it can only come from an experienced colonoscopist such as Raju.
No, it's not that. I want to share this. There is a very good article from Matsuda from Japan, who actually published the different subtle features, the different features of cancer for smaller lesions. And but if it takes time to look at those images, this is fairly simple to pick it up. One of the image that stuck in my mind is look at the surrounding area. And if you have a fold that goes, and then as it comes to the lesion, it becomes bigger and bigger, that is an indication for submucosal infiltration. So I'll actually try to share that article down the road so that people can look at it. It's a beautiful, one page. It will help you a lot. Okay.
So Raju?
Yeah.
So, in everyday practice, I think it's great that if you can look at the PIP parent and the parents classification, 1P, 1S, 2A, ABC. If you can do that, that's great. But here in the audience, how many of you routinely assess the polyp, whether it's a Paris 1, 2, or 3? Raise your hand. So only one.
And I had to learn fellowship. You see that? I had to learn after fellowship. So,
how many people are there in the audience there?
Only one.
No. How many people actually are there?
Oh, we have about 40.
Okay. So one. All right. So I wish I actually put in some videos about the Paris classification, but we'll actually, as we do the cases, we can actually look at it. Okay.
Hey, Raju, I want to make one quick comment before we move on, and that is just kind of listening to the panel, it seems like there are variations in terms of how people tattoo or where people tattoo. The only thing that I will say for the audience is, I think every surgeon is different. Every institution is different. I've heard some people tattoo upstream. I've heard some people tattoo downstream. The one thing that I will say is wherever you tattoo, it needs, my suggestion always is to make it crystal clear on your report. That way we avoid, if this patient goes to surgery, we avoid a non-target resection down the road.
Yeah. I think I'm glad that you brought that point. One thing is tattoos migrate. I think you think that you put a tattoo in one place and they do migrate. I've seen tattoos migrate quite a bit. It's probably best to, if it is a cancer, to put 3 tattoos, distal 2 on the anal side of the lesion, so that the surgeon knows, okay, he has to take 5 centimeters beyond that to cut it to have a clear margin. That makes it simpler for the surgeon. On the other hand, if you are seeing a case and you want to refer that patient to an endoscopy center where they do resection, then place 1 tattoo 3 to 5 centimeters distal to the lesion, probably in the same plane as the lesion, 1 injection, and take a photo of your tattoo and the lesion so that whoever is going to take care of the patient has a good idea of where it is. And then the question is, how do you put a tattoo? We're going to talk about it. I think Harish is going to talk about it. The best way to, not the best way, one of the safest way to put a tattoo without transmural injection is to take a needle and prime it with saline first. And once you prime the injection needle with saline, and then take that saline syringe out, and then put the spot or whatever tattoo injection, attach it, and then flush until the tattoo comes to the point of the biopsy port, and then that's where you stop. So you have another cc or more of saline in the catheter. So with that setting, you puncture and create a saline bleb, and into that bleb you fill the tattoo. That way you will have a submucosal bleb rather than a transmural bleb.
Hey, so, Raju, how about just start injecting the saline before you touch the mucosa? So as you go in, you inject. So the first sign of submucosal lift, then you know you shouldn't go anymore.
Right.
We have
we have one comment, Raju, and then we'll move to the next one.
Dr. Raju, do you think that AI will be useful in distinguishing between S1, S2, and basically invasive or malignant polyps in the future. It seems like an area that would be ripe for a meaningful change in practice.
Who am I listening to that comment? Could you introduce yourself?
Oh, this is Andy Tao. I'm with Austin Gastroenterology. I'm one of the hospitalists.
And it's very interesting that you asked that question. I was just flipping through the latest issue of GIE. There is a very interesting article. I think this article came from China, where they talk about the same question that you actually talk about. Kudo, the famous Kudo classification, wrote a beautiful editorial on that. It's worth reading that. You actually asked the question about, how do we differentiate? I think there is already some preliminary work in that area.
Thank you so much.
All right. Okay. All right. Let's go. So this is a second case. This is a screening colonoscopy, and as I'm coming down, I see this lesion. So I'm going to play this again, and I want to ask you, what is the size of the lesion? You can actually put it in there. It's going to be fun. This poly is very interesting. So
It looks like the price is right. I would go higher.
It's actually interesting. If more people put a particular number, that number becomes a predominant number. So. All right. It's still coming. Okay, so how do you want to remove this lesion? All right. Let me ask Rupa, let me ask Rupa and then the panel just comment on this. I want to hear your thoughts.
So this looks like a sessile serrated lesion, and then it's on a fold, maybe at the hepatic flexure, I don't know. What I would do is that I would lift it, and then after lift, I would cold snare it in one piece.
Okay. Chuck, what do you do?
I absolutely agree with a much smarter person sitting next to me.
You picked the right seat. All right, Jeff.
I am also sitting next to the smartest person.
Okay.
And
all right.
So what I would do is I would inject with methylene blue, because I still don't see. I think we're just seeing the epicenter so clearly, but the margin is unclear, which is often the case in sessile serrated adenoma. This could be adenoma or sessile serrated polyp. So if you inject a little bit of methylene blue, you will see the margin clearly. And then depending on the size, if it is a smaller than 1 centimeter, cold snare. If it is greater than 1 centimeter, EMR.
Okay. Kim?
I would agree with cold snare.
All right. And Phil?
I'd like to request to see the video again. I'm not too convinced of what I'm seeing.
Okay. You're a tough guy.
So I agree with the panel that there are some elements of this that may suggest an SSA, but I'm quite honestly not a fan of that little nodule in the middle. And that little nodule in the middle, to me, makes me wonder if this is either SSA plus something else or if it's actually something else. Where is this lesion?
Sigmoid colon.
So what comes to my mind, actually, is there a neuroendocrine tumor? And so I would actually, for something like this, you know, again, like I can't quite see the borders very well. One option would be to cold snare it because the whole lesion does not seem to be greater than 10 millimeters. But looking at that center portion, I might actually just take a single biopsy of that center first and then figure it out later.
Okay. All right. That's what initially I thought that, okay, this is a small lesion. Maybe I should get a biopsy or a jumbo biopsy and take it out. But what happened was, as I was looking through this, let me play this so that I thought that I saw something right here, a little bit weird thing going on. And then I decided that it's probably wiser to just inject, like Jeff and others commented, so that I could define a little bit better. And as you can see, once I inject, it is much larger than what we initially, this is what caught our eye, but we see a much larger lesion, right? You know, if you look at it here, right? So you can see the lesion all the way coming from here on the back side, and then on the front side, almost from almost 30 to 40% of the circumference. And we ended up cutting this with a hot snare. And this actually turned out to be SSL serrated adenoma. And they didn't mention about dysplasia. Like whenever you have a nodule, you wonder whether it's a SSA with the dysplasia, but they didn't mention that. I just take it as SSA. So we already talked about it. Any other comments on this?
So Dr. Raju, why hot snare versus cold snare in this lesion?
Typically, I've been using a hot snare. This is a video that was probably, 5-6 years old, And second thing is, if I see the same lesion now, knowing what I know, that we should be using more cold snare rather than hot snare. I don't like seeing blood, to be honest with you. When I do the cold snare, I don't, it becomes bloody and I can't figure out the margin. And then with a hot snare, if you actually tighten it almost as tight as if you are doing a cold snare and apply like one tap, right? Or it's almost like one beat and then it cuts. That energy is not necessarily, as we think, a lot of energy that will cause problems. And I want to make sure that the margin is completely clear. And when you do the hot snare, you have a clean resection, and then you can see the margin well. I always take photographs of the resection site, including the margins, and to convince myself that there is nothing left. And if there is any doubt, I routinely ablate that edge. So the reason I wanted to bring this case is there is a concept called a skirt lesion. The Japanese have come up with this. There is a series published in GI endoscopy. And when you see a lesion and you think, okay, this is SSA, you should ask yourself, is this what I'm seeing in my mind is a true lesion, or is there a lot more surrounding that? That's the concept of skirt lesion. And if you don't take time to look at and say and ask yourself the question, skirt lesion, yes or no, you will cut a lesion, and then when you go back, the lesion will come back. A high rate of incomplete cut and residual polyp coming back. And these, once they have a scarring and tethered, it becomes harder to cut. Any other take-home messages from the panel that they want to share? I think you must have seen cases like this where you thought, okay, this is a small lesion, but it's actually bigger than what we think.
Yeah, Raju. Actually, so one thing to echo here, and I don't think this has been brought up yet, but there's a lot of variation in terms of how people would approach this lesion, how people would cut this lesion. The only thing I would say to that is whatever method you choose, once you should start only if you think you could finish. And I think that's probably going to be a point that's echoed by the rest of this panel as well, that, you know, regardless of whether it's cold or hot, whether you like the sight of blood or not, you know, you should tackle this to completion, basically, and try to avoid leaving a lesion behind.
Yeah, I think I'm glad that you brought that up, Philip. One of the things that I share with my patients when I see them for resection of large polyps or flat lesions, I tell them that the goal is twofold: complete cut and a safe cut, right? Complete cut so that you don't have to worry about it coming back, safe cut so that you can go home after the procedure. So those are the two goals, and how do we manage those two goals? And that's what I want fellows to keep in mind as well. All right, so I just wanted to share with you another example for us to think through this, and I will run this one fast. You think that lesion is somewhere here. It is a subtle lesion, and as I take you through this, I started injecting, and then as I inject, you can see the lesion is, to my surprise, much larger than what I initially thought. And if I went ahead and decided to do straightforward cold snare, I would have left a lot of polyp there without resecting it, and then would be dealing with a recurrence later on, or incomplete cut later on. So, and another point for the sake of fellows is, when you use a snare, always pick a stiff snare. You know, you can pick whatever stiff snare you want, but pick a stiff snare and think about your snare as if it is like your tennis racket. You know, either you play forehand or backhand. You can play that by using a stiff snare, because you can anchor it at one side and then flip back, or anchor it on the other side and flip forwards, and it allows you to have that control. And the other thing is, always try to resect these lesions up to 15-20 millimeter lesions en bloc. And as you can see here, when I was closing the snare, my snare kept slipping, and my margin was not clear, so I reopened, and I wanted to get a little bit of normal tissue and then try to cut. Something to keep in mind, you know. And it's very important for you to work very closely with your assistant. You know, the assistant should be able to read your mind so that you can get a good cut. And following the resection, you want to make sure that your resection base is clean. And following resection, get into the habit of documenting your resection. You know, we normally don't do that. You know, we cut and then move on. But it's a good idea to document the resection with a photo. So I want to take, just rush through this section. I think important to recognize subtle lesions. And as the panelists said, you know, use a dye, either indigo or methylene blue, with saline or any other solution that is has those dyes to define the lesion. Any issue, either you could ablate with a snare tip, soft coagulation, or APC, and always assess the base to make sure the base is limited to the submucosa. All right. All right, let's go to the next case. So get into the habit of examining the image, a lesion with white light, NBI, and if you have an Olympus scope, adult scope, and I believe now pediatric scope has a near focus function to define the lesion and get into the habit of figuring out the optical diagnosis. So why don't I let one of the panelists to talk through this thing? Philip, you want to take a shot at it? I can play it again.
Yeah, so this looks like looks like a small adenoma, and it's actually good that you have the lesion on NBI and then taking a look on near focus, because that really helps to delineate the borders of the lesion. That way, it doesn't catch you off guard when you're trying to remove it.
All right. So let's take a poll here. So I think one of the things that I want to share is if you learn about the NICE classification, and this is the typical NICE 2. So the lesion is on NBI. The lesion is a little bit darker. You will see that once you see the lesion is darker than the surrounding. And then you have this linear vascular pattern, which you actually see better when you do the near focus. And another trick that you could use is if you have some problems with defining it, you can bring the lesion closer, and if you have a cap, you can press your air water button down so that the air water interference is gone and it will be underwater. You can actually see better. So this is a typical feature for an adenoma. Some of you may have thought that, okay, maybe there is a little bit of granular pattern, and that may have thought that, okay, maybe it is cancer. This has actually turned out to be adenoma. All right, and let's see, how do you remove this lesion? Ropa, how do you remove this one?
I would cold snare it.
Okay. Chuck?
You know, in community, we have LVU and we use LVU. Sometimes LVU can expire, and NBI, especially with the NICE classification, has made a huge difference on how we approach things.
Right. All right. So I want to actually run this next video. I agree. We'll do the cold snare, and maybe Jeff or Philip can comment on how they do and comment on the technique so that we have some take-home messages for the fellows.
So it's Jeff speaking. So I usually try to put it at 6 o'clock. And, you know, we've noticed that in the clips, you can rotate, but snares don't rotate. And sometimes it comes perpendicular. And as you grab there, I would get enough tissue to make sure that you have a clear lateral margin. And cold snare is quite safe as opposed to hot snare. And in cold snare, I just cut through without having to loosen the snare. But in hot snare, if I'm grabbing quite a bit, and if I'm worried about the center, I grab it and then let it go slightly and shake it to let go of the musculus propria, especially in the duodenal cavity.
All right.
So there's a very subtle move that Raju made as he was closing that cold snare there that I want to call him out on. And what he did was, I don't know what the proper terminology of this is. I was taught that this was known as planting the flag. If you imagine the shaft of the snare as a you want to basically plant the flag into the base of the snare, and that allows you to get a very precise snare closure so that it doesn't slip over the top of the lesion.
Philip, I want to...
And right there, right there. He kind of pushes it in ever so subtly, plants the flag into the base.
How did you read my mind?
Sorry, what's that?
How did you read my mind?
I did not.
But you know, when you do
your mind is unreadable.
But when you do cold snare,
Okay.
I think we all see that there's a little bit of white tail that you see oftentimes, especially if the polyp is close to 1 centimeter. That's perfectly okay to leave it alone. Don't go back and cut that.
Actually,
Right.
actually, Jeff, Chuck here, Doug Rex actually did a study because people were resecting those white tags, and he showed all submucosa. Yes.
Right. So actually, I'm glad that, you know, I tried to pull Philip's leg. I can't pull Philip's leg, but, you know, I admire Philip. I'm glad that Philip actually made that comment, and I wanted to share with you something. When you ask your assistant to open the snare, and as the metal wire comes out, right, you will see the wire open up. You should not see the metal straight part of the wire out. If you see that, your snare will have the stiffness that it needs. So when they open, you should just see the end of the plastic catheter and the snare opening without the straight portion outside your catheter. That is something important to keep in mind. The second one is, I think, beautifully, like you know, using the flagpole and putting a pressure down, and that will actually allow you to have a nice clean margin outside the polyp. You need to have a little bit of a margin. Because if you look at it, if you look into the literature, at least in the last 10 years, even 3-4 millimeter polyps, incomplete polyp resection is as high as 25%. So, but if you want to do cold snare, you want to actually have like a fried egg appearance, right? And to get that, I appreciate Philip making that particular comment, right? You want to post your catheter and press it down and get it. So thank you, Philip. All right, I want to actually run this video just to show another example, and maybe Philip could comment on this as the video is running. And for the sake of, you know, if you look at it, when we are doing screening, most of the lesions are small. If we perfect the way we do cold snare, we can do a lot to our patients, and something to keep in mind in terms of having a good outcome, right? You know, right. And this is what Chuck is commenting on, that white area. And it is submucosa with a little bit of muscularis mucosa that is popping up. You don't have to worry about that. So, all right, this is the end of this, and maybe the panel could comment on certain things that they want to share while I close this session and reopen the next session.
So I just want to make a quick comment. If you're doing large polypectomy in a very difficult position, at the end of the day, you might want to call your colleague to come in and help out. And I think that's very helpful. When I went to Japan to learn ESD, they always worked in two. I thought that one was a fellow and the other was the attending, but they both were attendings and very difficult cases. And when one got so tired, the second one jumped in to tag match. It's like a wrestling match, tag team. And the result was beautiful. So if you're so tired at the end of the day and you see a huge polyp, don't try to be, a solo player trying to cut that out.
Kim, any comments in terms of the learning points and Rupa?
So one of the things that I'd like to ask the panel, and what you do, is occasionally with the cold snares, you'll have a little bit too much tissue and aren't cutting all the way through. And how do you handle that?
All right. Maybe the panel can take it, and then I'll answer.
Well, Kim, like what Jeff said, I'm jiggling the snare to disengage the muscularity. It was highlighted years ago, and I think it's a great technique. I've not seen the target sign just by doing that simple thing. I'll give it to Rupa, though.
I have another question. When we're doing cold snares on large polyps, kind of mid-sized polyps, if there is bleeding, how would handle the bleeding?
So bleeding is not as scary as a perforation. I'll take bleeding any day over perforation. So if there's bleeding, you still have a lot of time. Patient is obviously has a high enough hemoglobin to undergo the treatment. So the patient can bleed for some time. And doing ESD, as Phil does every day, you see bleeding quite often, pumping. You expect it. If you don't expect it, when it comes to you, you get surprised. But when you're expecting it and be ready, soft coag is very good. Coag rasper is very good. You can compress on it to stop the bleeding. And if you find the location, you can just buzz it. And soft coag is your friend. So when I do, I use a cut, not coag. Yellow, not blue pedal, especially on the right side. So when there's bleeding, you still have a lot. And then if you can't see the bleeding source, you can start injecting some epinephrine to slow down the bleeding. That's what I do.
All right. Phil, you want to take it before we?
Yeah, for me at least, I find cold snare to be one of the safest things that we do. I think it's an extremely fantastic tool, and I think it's you basically you're trading off the timing of hot snare something. No offense, Raju, but the bleeding comes later when you're not staring at the colon. When you cold snare something, the bleeding's right in your face, and when it stops, it stops. And I think generally speaking, with a cold snare, especially at like a 10 millimeter level, it's unusual to have any cold snare where it bleeds persistently. And if it does, then you could just put a clip over the lesion and close like you would for a hot snare.
Yeah, I think first of all, I really appreciate you all sharing those thoughts. And to answer Kim's question, if you take a cold snare and then you're not able to cut it through, right? What do you do, right?
Sorry for that question, I think I usually kind of reopen it a little bit and then just kind of wiggle it like Jeff and then reclose it and try again.
Yeah, the thing is sometimes we are stuck. The cold snare doesn't cut through for whatever reason. I have no explanation. And when that happens, I just reopen and then try to cut hot. That's what I've done. The thing is, just for the sake of audience, I don't have any interest or anything with Olympus conflicts. In our lab, we have Olam snare, the snare master, that is the cold snare, and the master plus, that is a cold snare with snare, with electrosurgical connection. And I try to use the Snare Master Plus as my routine cold snare resection. And if in case I get stuck there, instead of reopening and trying to just apply some current and cut it. And that might be something to, again, if you have to reopen and then try to get it, the edge will crumple and other issues. So that is something to keep in mind. One thing you don't want to do is, if it's not cutting, try to pull. You're going to rupture the colon. So, all right. So this is another case. Actually, this is somebody that was sent to me for resection of a large polyp. And in addition to resection of a large polyp, I found, you can see the clips higher up. It's a difficult colon. As you can see, I keep slipping back, and I see this lesion here. All right, and so what do you think is this lesion? All right. I'm glad that the rest of the option silent. That's good. And let me ask the panel, how would they manage this lesion?
So I'm one of the 100% here. There's a mucus plug on the surface, mucus cap, and it looks like a SSA, sessile serrated polyp. And definitely the problem is, once that outer margin is not that clear, so we have to delineate how far the tumor has spread. So I would definitely inject some methylene blue or indigo carmine to better assess the margins.
Okay. So Jeff, do me a favor. Ask this question to the audience. This is an SSA. Everybody agreed. How many people would go ahead and do cold snare resection?
So can you raise your hand if you are willing to do cold snare? Raise your hand. Okay. We got 4 outstanding gastroenterologists, including the past president of ACG, saying he's going to go for cold snare. So, Harry, do you want to come to the microphone and give a... Or Harish? Harish? Why you would choose cold snare?
All right.
Harish is coming to the mic, Raju.
Okay.
One of the disadvantages of cold snare is you really can't delineate the edges of the lesion. So I will still snare, but I will inject with any of the solutions you use in your practice, and make sure that edges are delineated. Still do cold snare, and there's clearly now data showing that even if lesion up to 4 or 5 centimeters, if your sessile serrated adenomas, flat lesions, you can very safely resect with cold snare.
So a rebuttal that, Harish, I agree that you can cut 4 centimeter lesions cold, but it'll come out as a piecemeal, not as an unblock.
That is correct.
All right. Okay. So this is what we did. I think for the sake of trainees, always you want to go to the cecal side of the lesion, and before you inject, flush your catheter. Ask your assistant to flush, to make sure there's no air, because you may think that it is primed. You have to confirm it's primed. And then you ask them to inject like a tap, right, so that a small amount of fluid comes. And once you know that you're in the submucosa, the assistant has to work with you as you change the direction of your needle to get a good lift. One important thing to keep in mind is when you have a lesion on the top of the fold, that is the highest risk lesion for perforation when you do EMR or any type of heart snare resection. And the other thing is this lesion, as you can see, there is scarring here from a previous biopsy. You can see that, right? You can see that scarring, right? So I wish I could go back and show you the scarring in the original video. It's important to read the lesion, find out where the scar is, and you stay away from the scar. You want to go away from the scar when you do the injection so that you have a good lift. If in case you injected around here, I can assure you that you will create a mucosal bleb, and that mucosal bleb will pop and it will make your resection a mess. So important to find out where the scar is and go away to inject so that you get a good lift. So something to keep in mind. And then, as you can see here, again, we used here a hot snare for resection. And I just want to show you how we did, because this is a lesion that is a little bit difficult. This is on top of the fold, and you also want to keep in mind the stability of your scope. As you can see in the first video, when we are looking at the video, my scope slipped back. And those are the things you want to keep in mind and figure out what's the best way to cut. And this is what I'm saying. You don't want to see that metal outside. You want to see just here when it's open. And then as you close the snare, you have to have some faith that your snare is going to entrap the lesion from the other side as well. That is, you'll get a feel for that as you gain a lot more experience with the resection. Always keep in mind, whenever you have a polyp on the top of the fold, think about perforation. It's going to happen. So here you see these folds bunched up, and when it's bunched up, it's possible that I may have entrapped the muscle. And in that case, I want to reopen the snare a little bit, distend the colon, and then close it again. By doing the distension of the colon, opening and then closing, you let the muscle fall back and you'll be safe from getting into a problem. So something to keep in mind. Here is a scar, and we're trying to resect. And in this case, we just use endocut Q313 setting. That's what I use. And after the resection, get into the habit of again documenting your resection. Right, your margin is clear, and your base shows whatever findings. So here, let me ask Philip, how do you assess the base for the sake of trainees to
a polyp, of course, understanding the layers of the colon. So the mucosa, mucosa is mucosa, but all that stringy stuff underneath, that's all submucosa. You don't typically see down to muscularis propria during EMR like this. Muscularis propria is more typically seen during ESD. You don't quite see it at an EMR level. And again, it has to do with, when you close the snare, you kind of shake the snare a little bit to free up the muscularis propria. What I look for at the base, I tend to look for exposed vessels that may bleed, and I will typically cauterize those with like either a coagulation forceps with like soft coagulation type setting. I will also take a look very meticulously along the entire border of the resection defect as well, to look to see if there's any evidence of recurrence, and if there's any concern about that, I'll ablate the borders. Raju here is using, I tend to use some soft coagulation, and I don't think there's necessarily a right or wrong answer in that regard. With regards to the base itself, you know, when you do cook the base, if you will, with coagulation or with APC, just you know, be careful that you don't produce a transmural burn and give the patients post-polypectomy syndrome.
Thank you, Philip. That's really nice. I want to ask if you could poll the audience. How many people in the audience use OB generator? I just wanted to see, so that I want to share something that might help them in their practice.
If you would raise your hand. Majority, if not all.
Okay.
Yeah.
Ask them how many of them have endocut on the left side and forced coagulation on the right side.
So you heard the question very clearly. So if you do, please raise your hand.
Endocut on the screen, endocut on the left side, forced coagulation on the right side.
Once again, majority.
Okay. How many of them would have resected this with the endocut?
So how many of you would have used the yellow pedal? Blue pedal? It's a little bit split, but yellow cut is more predominant than coag.
All right. So for those who use endocut and as a predominant mode, I want to share a trick. I should put it a trick. Something that I changed in my practice maybe for the last four years. So when the machine comes, you know, it is automatically set at endocut on the left side and forced coagulation 225 on the right side. That's how every machine is set up. If you look at, okay, and you're doing EMR as your practice, I would automatically change my forced coagulation to soft coagulation, and maybe 2 and 50 or 60 or 70 watts, whatever you want to use. And that's my setup. So when I'm doing my polyp resections, EMRs or whatever, I have endocut on the left side and soft coagulation on the right side. I'll tell you why. If you resect and you see bleeding, right? Once you resect, you don't pull the snare out. You keep your snare inside your field to make sure that there's no bleeding for a few seconds. If you notice bleeding, your snare is already there, right there, right? You don't have to put it back. And your OB machine is already set for soft coagulation. That means all you have to do is touch that bleeding vessel and apply a little bit of blue pedal, and it will seal off the vessel. You don't have to go through the agony of asking your endoscopy assistant to change from forced to soft, and usually they make a mess out of it. You probably have to do it yourself. So you don't have to go through that. The second one is, if you get into the habit of ablating the edge with the snare tip soft coagulation, you have the setup there. So something to keep in mind, which will make your job a lot easier if you can change your settings, left endocut, right soft coagulation. But that doesn't work if you are looking at a large pedunculated polyp and you want to do forced coagulation, then you have to change your setting. But if you look at it, most of the lesions that we are seeing are flat nowadays, not big, thick pedicles. So it will save you a lot of hassle.
Dr. Reggie, Dr. Ganesha has a comment.
Yeah. Go ahead.
He's coming.
This is a comment regarding, I think Phil made a comment regarding at the base, there are visible treatment of the vessels. But I understand that there's a study by Michael Burke which clearly showed, it's a large study, that treating the blood vessels at the base, which you can think that it's going to bleed afterwards, is leading yourself and not the blood vessels, because it does not make a difference. So I just want to make that comment.
So, Harish, that's really a nice point. And then there is another study in the same line. Endo clipping, does it really reduce delayed bleeding? The juries are still out. Some say yes, it does, and others say no, it doesn't. So, looking at the cut surface, Harish, you may be right. The cut surface on this one was quite small, smaller than 1 centimeter. You might have gotten the entire thing as a one block cold.
So on that regard, anything on the right side more than 2 centimeter, meta-analysis showed that okay, you can treat with clips, but there is clipping and there is clipping. This clip technique is also very, very important in that regard. Yeah.
So I want to show you, like as you're seeing it, when you want to apply a clip, you want to make sure that you use the clip properly and that approximation. And when you are looking at deep approximation, you're as if getting onto the top of the house with both legs on either legs, one leg on each side. So that's the goal you should have. And once you have that, you want to push the clip a little bit as your assistant is closing so that you can compensate for the clip retraction. That way you will achieve what is called a deep approximation. When you achieve deep approximation, you have less chance of clip dropping off, quickly, and it will stay there for a long period of time.
So when I watch Raju clipping, it's really an art, and he has taught me the sequence of clipping. And if you end the result, if it's not lined up perfectly, it's not perfect. So it is really nice. But one thing that really helps me when I'm clipping, suction. If lumen is distended, it's very hard to oppose large gap. So applying some suction helps.
So a question for Raju and Phil. This is more for larger defects. This is Emmanuel, by the way. What do you guys think about the new back closure system that was by Apollo?
I wish I could comment. I have no experience, man, to be honest with you.
So, interesting question. So, I've used it a decent amount for EMRs as well as for ESDs in the colon. It's, as Jeff had mentioned earlier, it presents a alternative to clip closure, especially in the right colon. So it's definitely an attractive idea. For those of you in the audience who are not familiar with this, this is what's known as the X-Tack. It's basically, if you imagine a single suture, so if you imagine like a fishing line with 4 metal screws, like 4 tacks, and if you imagine like a circular, resection defect, if you put a tack on 1, 2, and then 3 and 4, and then you kind of pull it together like a purse string, you can achieve a closure of a defect. I believe Apollo says it's up to about 3 centimeters or so. And it's meant to be a very robust closure. Now, obviously, your results may vary, but my personal feeling about it is for most of us who have tried to use it, there is a significant learning curve involved. It does take at least a couple of tries before you become very facile at it. I would say if there was, for example, a perforation during EMR or during polypectomy, the amount of time it takes to pull this thing out and to have a tech who actually knows how to use it and to actually use this device, you potentially would be losing very, very valuable time where you could have already closed it with simple endoclips alone. So that's my 2 cents about the device. I think that the device is still very much, even though it is FDA approved, you can freely buy it. It's very much a device that's still in development in many ways, and I expect to see multiple future iterations of this before it really becomes mainstream.
So I 100% agree with Phil, and but there's an alternative. Alternative is using a clip. You know how to use a clip. And you can put dental floss on the clip and then clip opposite side of perforation or mucosa defect and leave the dental floss attached to it. And then put another one on the other side, and then you can actually pull them together. Pull 2 strings of dental floss, and you can oppose that, and then you can put a clip on it. That may be quicker and easier at this time. Having used the X-Tack, it does require a lot of experience before you actually use it in perforation.
Right. Thank you. All right. I just wanted to take a little bit of time to just show. We talked about the tattoo technique. And here, as you can see here, we are injecting, creating a saline bleb first, and then into that bleb, put in the tattoo. When you're, for the sake of fellows, when you are putting tattoos in the cancer setting, always put the tattoo in the dependent portion first, so that if you, for some reason, fills, it doesn't make the whole area dirty. So in a cancer, you have to put at least 3 or 4 tattoos. But if it is a follow-up of an EMR or whatever, you want to put a tattoo just close by. So you saw that, right? We injected a little bit of saline and then filled that with the tattoo. So that would make it a little bit cleaner. And also you can avoid spilling it into the peritoneal cavity. And for those of us who have been practicing for a long time, when we started injecting India ink, there were lots of complications, including rectus sheath abscesses and others. I think the senior gastroenterologists are that. So by this technique, you know that it is into the submucosal plane rather than going outside. All right. So this is a next case. Actually, I would like, I want to show this thing. This is a 66-year-old man with a polyp that was referred to Phil G. He was referred for endoscopic resection, and the outside endoscopist said it was very challenging to reach that site. But I'm glad that he was able to reach that site. And let me ask the panel, starting with Rupa. When you have a difficult colonoscopy, how do you plan that procedure?
Just one thing real quick, Raju. The only other comment I would throw in there is that the first endoscopist who found this lesion had actually attempted to inject to lift this lesion for an attempted EMR, and the lesion was found to be completely non-lifting.
Okay, good.
So if there is a polyp that is difficult to resect because the location, and also if due to the breathing, and it moves and you cannot get a good position, I think the patient should be on anesthesia so that they're completely sedated up there. And filling the lumen with water, that kind of helps sometimes. And cap assisted colonoscopy also helps too, to kind of have a grip on the polyp. These are the things that I would do. And obviously, if it's looping excessively, reducing the loop as much as you can and changing the patient's position. And if not, using an overtube, that will help, to reduce the looping.
All right, Chuck, what would you do?
Same kind of thing, and I've actually done a couple of colonoscopies with general anesthesia for what Rupert was just talking about, using positioning, using stiffeners. So I'm in concurrence. I am interested if there were details about how it was non-lifting, where he injected, things like that. Before going on, I really don't like how the center of this polyp looks also. I'd love to see it under MBI or Eleview, but I'll defer to Jeff and Kim for other
All right, it's good. It's good. We want to see how each one of us does, so that the trainees can learn. There are different ways of addressing a problem. All right, Jeff.
So the colonoscopy itself was difficult because you can't get there. Then I would consider using Pathfinder. So Pathfinder is a new device. If you make it as a S shape, it'll stay as a S shape. It doesn't become a linear tube, but it stiffens. So it makes you go through the tortuous sigmoid better. So I might use that. And the second issue that we have, so once you get there, now you're comfortably there, but you still have to deal with the polyp that's not lifting. So then I would quickly do endoscopic ultrasound with a probe to see whether it's a T2 involving the musculus propria layer. And if so, then I would consider doing full thickness. I think Phil is an expert and Emmanuel is an expert in that.
Okay.
So I would comment more on the looping. I mean, you want to keep that polyp in as good a position as possible, hopefully with no loop in. So often what we will do for looping is start out with a hand on the belly just to stabilize, to use predominantly fluid or water to get around, and to do frequent reduction even before one feels like that they have a loop, just to keep the scope as straight as possible.
Right. Thank you. Thank you. All right. So these are all the different options that you covered. And what I would like to do is I will ask Phil, who did the case, and this is his video, and let him talk about it. I think it will be a good learning experience for us. All right, Phil.
This is the what's known as the Pathfinder. Jeff correctly identified the device. Basically, what it is, it's what's known as a dynamic rigidizing overtube. So it's an overtube. It originally only accommodated a pediatric colonoscope. It's adult colonoscopes as well. It's attached to a vacuum suction, and with basically a flip of a switch, you can make this tube completely rigid, as we demonstrated here. On the bench top. This is footage from the actual case, where basically it's a very similar idea to balloon-assisted enteroscopy, and for I guess the older generation in the audience, this is very similar to a device known as the Shape Lock that was out in the commercial markets a number of years back. Basically, you advance as far as you can, then you advance the overtube. And then after you advance the overtube, you then stiffen the overtube, and then you're able to advance further. So it's the I think right there. Yep. So here we have this is a flexible state, and then you can make the whole thing rigid. And once you have the whole thing rigid, you're able to advance the scope further. And this allowed us to be able to reach the polyp in a endoscopically stable position. The original problem with this lesion was that you could reach it only with the scope completely hubbed and with fully paradoxical movements. This allowed us to reach the lesion and fully reduce, so that we had one-to-one control of the scope tip. With regards to the resection itself, this ended up being an ESD case. And I don't think Raju was planning to go into the details of the resection for this purpose.
Any tricks that you want to share that people should learn?
I think it's kind of being aware of the different techniques or the different tools at our disposal. The Pathfinder is a relatively novel device. The paper just came out in GIE within the past year, and it's produced by a very small startup company out of the San Francisco Bay Area. And this may be something that most people are not aware that it exists. Just kind of being, anyways, just being aware that there are different ways to reach a polyp safely. I guess in terms of endoscopic resection, One of the key learning points is to only resect when stable. One of the worst things you can do is attempt to do a complex resection like EMR or ESD or whatever in between, and doing it from an unstable position without good scope control, especially if it's looped or paradoxical. And the reason is because for all these types of resections that we do, you have to be prepared to also close too in case of some sort of mishap. And if the scope is unstable, the closure will be unstable as well.
Okay, beautifully done. Jeff, could you ask our members, anybody has used this?
So can you
raise your hand if you have used it before?
Yeah.
Okay. Actually, this has certainly changed. I see that Emmanuel and Philip did quite a few cases, including the complex upper GI stenting cases with a large stomach, trying to put a duodenal stent. I think they were able to do some complex cases. There's multiple uses.
So
Emmanuel actually has a very large collection of altered anatomy ERCPs that he has done with this device.
So we have to give a little bit of caution because, Whipple procedure, the angulation into afferent limb is quite steep. So yes, we have used it. Emmanuel has done multiple cases, beautifully done, but still you got to, because this is not designed for that. And so you have to really have a good feel of what kind of pressure you're going through. Just like when you do colonoscopy, the most common location of perforation is the center, right? So if you're doing an altered anatomy using this, you really have to be careful not to cause any perforation.
Yeah, that's a good point. That's a good point.
Jeff, I have a question. Is this device safe enough to use in colonoscopies where there's a large ventral hernia with colon in there?
I'm not sure whether it's safe to use. And I'm also not sure whether it's safe to use when there are so many diverticuli. I have not used it in those situations. I've used it in the cases where there's a looping and very difficult to advance the scope. So then I use. Yeah.
I think you're right. It's probably, I've not done many cases, but looking through and having done just one case, I felt that this instrument helped me in a case where there was a long mesocolon that allowed the colon to flip-flop, and the colon caliber was so big, even the adult scope was flip-flopping inside. I recently did a case where I failed before, and 2 people outside failed before, and I'm glad that we had this instrument. We were able to give him a clean exam and said you don't have to go through barium NMRs and CTs and other things. I think in that, when you have a narrow, angulated, fixed sigmoid with a lot of diverticulosis and a lot of adhesions, you don't have that feel, right? You push that because this caliber is much bigger. So something to be a little bit careful about. All right. So this is a large cecal polyp, and this is a video that is thanks to the collection from colon perforation DVD that we created a long time back. And this is a cecal polyp and resection.
I mean, that's a scary hole there. Yeah.
Yeah. All right. All right. Let's see what the panel would do.
That is an amazing target site. So, first and foremost, thankfully this lesion is not in a dependent part of the colon. You don't have, at least you don't have liquid spilling out of the target. One of the first things that I did encounter a colleague who will go unnamed, who had something like this happen to them, and I was helping him out. I think he was kind of in disbelief that this had happened, and he was fixated on the mild oozing of blood along the rim because there were some mucosal and muscle vessels in the area. He kept pumping water through it to wash the blood off. I think, of course, patient codes now what, but anyways, even before then, my first rule of thumb is don't let stuff leak out if you can avoid it. So don't put stuff through it, don't wash through it, make sure the patient is already non-dependent. If the patient is dependent, please make them non-dependent. Make sure that you're on CO2 if you're not already on CO2 when you do these types of cases. And yes, patient codes, what next?
So the codes, not because of perforation, probably because the pressure building up peritoneum is the peritoneum. So a lot of air or CO2 is now compressing there's compartment syndrome. So that's probably what caused the patient to have asystole or code. I don't know, Katie, Prashant, are you here? Yeah, Prashant wrote a beautiful article in the AGA, Clinical Practice Update Advice, along with me and Stavros and David Carlock, and he talks about using the needle, where to poke to relieve the pressure.
Why don't you share that? Jeff.
Yeah, I'll have a Prashant talk about it, and he's coming. Okay. It's in CGA, Clinical Gastro and Hepatology.
Thanks, Jeff. Jeff was the leading author on that paper. Just citing me is a nice thing to do. But basically, yeah, so whenever I encounter a perforation, I think the first thing to do is take a deep breath and calm down, because that's the first thing you can do. Lose your nerve, get a little nervous. The whole staff starts feeling your anxiety. The anesthesiologist or CRNA feels your anxiety. But if you keep your composure in the room, that helps you lead the team and do a effective closure or manage the patient effectively. I think that you should be doing cases with CO2, especially therapeutic cases, high-risk cases, EMRs, in the right colon. You should be doing them with CO2 now prophylactically. That's like driving with your seatbelt on, in my opinion. And if you don't do it, you counter a perforation, you don't realize it, you're putting so much air into the belly, you can have those situations. I guarantee that situation probably happened in the setting of using air and not CO2, because CO2 is like 200 times lighter than air, and it won't cause that problem. Next, I would give the patient antibiotics immediately. I'd have the anesthesiologist give them antibiotics, and then I would, exactly what Dr. G said, clear the field. Make sure that there's no contamination from the first space into the second space. Once you've cleared the field and you know you can safely work, then you can start thinking about closure, and I'm sure you guys will get to closures and where you are on the colon and clipping and whatnot. This use of a Varese needle or a type of angiocath to decompress the peritoneum, sometimes this happens when we're doing third space or POEM or whatnot, or in perforations like this where you have air escaping into the peritoneum. And in the retroperitoneum, you can't really do much, but in the peritoneum, you can kind of percuss where you feel tympanic space. You can do it in the upper belly, you can do it in the lower belly, but if you're using a smaller gauge needle, once you push in, just how they use with the fluid, once you see the air bubbles there, you can just take off the syringe and air will come out and you can just actually hear the air. If you have a specific Varese needle, this is what surgeons will use in the OR. It has a little ball on the top of the needle where when the air comes out, the ball will shake. So you can actually use that as a gauge to see whether you're in the right space or not. And once you do that and you get into the right space, you just put some gentle pressure on the belly. All of that air will kind of come out. The intra-abdominal pressure will decrease. Your hemostasis will improve, and you'll have a more stable condition to do things. And you can leave that needle in, especially if it's a Varese needle. It actually has a blunt tip. at the end to protect bowel perforations. If you use like a regular angiocat, then you do have a risk of potentially hitting another loop of bowel and causing damage. So I like using a Veress needle because it's meant for this purpose and for safety. So having that in the room, if this scenario arises, is always a helpful thing to do.
Oh, thank you, Prashant. It's beautifully said. And I want to congratulate you and Jeff for writing a beautiful review article, and encourage everybody to read that. And what I would like to do is I'd like to go to the next set of slides. Just bear with me. And maybe the panel can comment. One of the things that this is quite a old video, almost maybe 10, 12 years ago, when we are still learning about perforation or whatever. And one thing is, you can see that there was a lot of fluid before the cut was made. And nowadays, if you want to cut, you want to have a dry field before you cut. And if in case you have a perforation, at least you don't have the fluid escaping out and causing problems. So let me get this other one, and then we'll do them.
So while you're getting that ready, one other thing that Prashant mentions in the article is there's a big difference between immediate perforation management and delayed perforation management. If it's an immediate perforation, you have a very good chance to close that. But if it's delayed perforation, patient comes back because you didn't realize there was a perforation, or there's a target sign and you missed, or there's a thermal effect that eventually caused the perforation, patient will come back with a peritoneal sign. You don't need to go back in. The patient needs to go to surgery.
Yeah, yeah. All right. All right. So the other thing is, we all try to retroflex as a part of a routine. Sometimes that can get into trouble. Here is something that happened, and Jeff, Philip was called in when one of our colleagues had an issue. All right. And let's see what the group will do. How do you manage this one? Call a surgeon, clip close, vacuum therapy, suture closure, none of the above. So this is a lesion low in the rectum, something to keep in mind. That way at least you guys have an idea. Because low in the rectum or high in the rectum makes a difference where the peritoneal reflection is, whether it will lead to retroperitoneal perf or free perf. So it is low in the rectum. All right. So let me ask actually Phil, who has done a beautiful job, to take you through this video and what was going on in his mind. And then, so Phil, why don't you talk about why you chose whatever you chose before I run the video?
Yeah, so this was literally one of those kind of calls for help where I was walking down the hallway and a nurse comes running on and goes, help, help, help. And I was like, well, what do you, that's kind of bizarre. So I walked in and I saw this. And, I think in the rectum, it is important to understand where you are because it has a lot to do with how much time you have. So this was in the distal rectum. So it's below the peritoneal reflection. So this is perforation in soft tissue, into basically perirectal soft tissues. The next question then becomes, well, which part of the rectum? So in a standard colonoscopy, that right wall there, that is anterior. The wall opposite would be posterior. The wall above you would be the right side, and the wall below you where the water pools is left side because the patient is left lateral. So those are all considerations in terms of just kind of getting a sense as to how critically urgent is this? Is this the patient that's going to code like the last one, in which case time is more of the essence, or is this something where you can afford to try to get a more durable closure? So we also had the benefit in the room that there were, the call for help attracted every tech in a 1 mile vicinity, and so. With a number of techs in the room, we were easily able to get a endoscopic suturing device set up. Basically, in the amount of time that it took to get gowned up and to control the scope and suction down in the rectum to make sure that it wasn't overly distended. Literally within less than 30 seconds or so, there was a suturing device and a double channel scope ready. So I then proceeded to suture the lesion closed. Raju, I believe that is unedited video aside from it being sped up just a tiny bit.
Okay. I want to make one point that you actually pointed out. This is strictly for the sake of trainees. You mentioned that the perforation is on the anterior wall. And the reason I want you for the trainees to keep that thing in mind is when you come into the rectum and you see a lesion, like say for example, you see a lesion that looks like carcinoid, right? Which are very easy to miss. So how do you put a report? How do you report that finding? So put some water, make sure that the water goes down at 6 o'clock so that you know with the patient in the left lateral position. So you know that is the left wall, and then knowing where the left wall is, you know where the anterior, right and posterior walls are. And then when you describe, don't say a submucosal lesion at 5 centimeters. You want to say submucosal lesion at 5 centimeters, anterior wall, posterior wall, right or left. So something to keep in mind. We don't normally put a tattoo in the rectum, right? We don't. But if you think about that this lesion is a carcinoid tumor, probably a good idea to put a small tattoo. That's one indication where you can put a tattoo so that the referring, when you refer the case to an advanced endoscopist for resection, he's not wasting time looking for that. He will easily find that. Okay, coming back to the case.
So one comment I want to make in addition to that, the anterior wall of the rectum carries significance in female patients because on the other side is the vagina. And this is something where colorectal surgeons tend to appreciate more than just because they have more of that training. And that is that the rectal vaginal septum that separates the walls of the rectum and the vagina is typically only approximately 2 to 3 millimeters thick. And so the anterior wall is important to pay attention to with regards to anything that might violate the wall and therefore violate the septum.
All right. I see that David sent me a message. This is David Greenwald, my good friend. Why don't you comment on what you want to do for this case, David?
He's coming up.
Thanks, Raju. I was trying to hide in the back. That didn't work very well. Nice to be here in Texas. Hey, Jeff. I was actually asked, what I asked you was about the last case, though, the post-pulpectomy perforation. I mean, you mentioned clipping and suturing and so forth. So we've been using a little bit of a device called an X-Tack. I don't know if you guys have been using it or not, but it's sort of a little couple of like posts that you put in, and then you can purse some sutures together. And it creates quite a nice closure in a little bit longer than some of the more conventional approaches, but with probably a better seal. So basically what I texted you was,
Right.
What do you think of that?
Right. I'm glad that we want to bring you to the front end because in Texas love you. So.
Oh, that's sweet. I love you too. I'm going to go back to hiding.
Yeah. No, actually, if you look at that clip, that clip is an Olympus clip, right? And that video is a very old video, maybe in the 2005 or 6 time when we didn't have a lot of these other clips available. And so it's actually thanks to Roy who shared that video with me. And what you shared is actually worth for all of us to learn that X-Stack so that when we get into trouble, at least we have another setup. And let me give this to Phil to talk about the technique. Phil.
Yeah, so endoscopic suturing does carry a little bit of a learning curve. I was taught this as part of my advanced endoscopy fellowship, so I've gotten quite a bit of a hands-on use with it. But generally speaking, this approximates surgical suturing, where this lesion is sutured in. You can see here, this is an outside in, and then the next bite is taken inside out, and it's a single long running stitch from right to left. Right to left is preferred when you suture because of the orientation of the device. I ended up suturing this in 2 layers. So I created a single running stitch across from right to left, and then I reinforced it with a second layer suture going above the first one. This patient, she woke up with no pain at all. She received antibiotics, was watched overnight in the hospital, went home subsequently. I brought her in out of curiosity about 3 months later for a quick flex sig, and everything was very beautifully healed by then.
So I'll make a comment on both, not to ignore David's question. Yes, in our article with Prashant, we mentioned that the only device that we had in 2005 when Raju made the video, it was only EndoClip. You can use Ovesco, you can use endo suturing because you have to change the scope and you can't really get there. But now we have X-Tech, which requires some learning curve to use. So yes, we have both options now. And here, you really have to have a good skill in doing endo suturing. So for most of us, it may be just quicker and easier to use Ovesco, but as Phil mentioned, you don't want to suck in the surrounding structures. So then you can use the forceps that comes with Ovesco, and you can pull that edges in. You can grab each edge and oppose and pull into the cap, and you can put a clip on, which may be quicker.
Yeah, that's a good learning point, Jeff. Thank you.
Raju, Prashant has another comment or question.
Yeah. Yeah.
So just kind of a comment on Dr. Greenwald's point, and then a question to the panel about their thoughts about this. So with the X-Tac system, it's a little different than suturing. So as you can see, very beautifully demonstrated in this video by Dr. G, when you suture with the overstitch, it's the sutures that are grabbing the tissue and that suture is approximating. So you can see how tight it pulls that tissue together. The X-Tac system is a little different in that it's 4 corkscrews of metal that are attached to a suture, and then you're pulling those metal corkscrews together. So how tight that approximation is, how tight you'll prevent any contamination of fluid across a field, I don't know. I think for appropriate, but for a full thickness closure, I question how good it's going to be as compared to an overstitch device. So in the left side of the colon where you have overstitch available, I would prefer the overstitch. If you're in the right colon or in the cecum when you can't necessarily suture there, X-Tac would seem like a reasonable approach, but I have some concerns about whether it's going to be as good for full thickness perforations compared to overstitch. And I don't know what the panel, Dr. Guy, if anybody has thoughts on that, or Dr. Greenwald.
So yes,
yeah,
I agree. It does cause some gap when the 4 metals come together. There's at least a theoretical gap. So I would just go ahead and reinforce that with the clips. Once you have opposed all that, what is remaining, including the muscle layer, then after you approximate it and closed, I would just still reinforce it with the multiple clips.
Yeah, I would agree. Like if you're in the left colon and you don't have overstitch available, but you have X-Tack available, you're in that setting, I would make sure that you're doing a little extra than just that for a full thickness perforation.
So I completely agree, and thank you for the comments. I completely agree with the comment about X-Tack and whether it's actually robust enough. So when X-Tack came out, I started religiously using it for closure for ESD. And a little bit of background about what I do. I'm notorious for leaving ESD resection defects wide open. And when X-Tack came around, I thought it's fantastic. Maybe I'll start closing these things, and maybe we can certainly see if this works or not. And it didn't take more than a couple of cases to realize that even after you get past the initial learning curve, that when these 4 metal tacks come together, there's a lot of metal in a very small area. And all that metal in a very small area produces a gap. And I started wondering to myself, that's nice, I'm closing submucosal defects, but if I were closing something full thickness, would I trust that? I don't know what the data is going to show. To my understanding, there is a multi-center clinical registry that's being gathered or whatever. But to me, in the right colon, I think time is more of the essence as well. And quite frankly, the amount of expertise amongst techs and assistants, or even amongst endoscopists, it may be faster to just, if you have good clipping technique, to just, especially like Dr. Raju, you would just clip close it. You would have a much more reliable closure. Now, there are times when I feel like the angles, for clip closure may be super awkward. In those cases, it may be worthwhile to try using X-Tack, because you have a very different perspective in terms of the closure. Like, you don't have to be necessarily right on the actual defect itself. You just kind of put the tacks on the 4 corners of the hole. So those are my 2 cents about this.
Good. Thank you, Andy. We have a comment, and then we're going to move to one more case. I know we're pressed for time.
There's very quick comment. There's new clips out that are much larger. The Ultra Boston Scientific clip is a much larger clip. Again, that clip, unlike any other clip in the market, I have no conflicts of interest. You're able to rotate the clip. The physician is able to rotate the clip at the biopsy port. The only clip that's ever been designed to be able to do that, and it's got a much larger mouth. So when I saw that one, I would get scared, right? I start sweating, but that would be the clip that I'd probably go for. And once you're starting to close it, you're right that sometimes there's awkward angles. You can control the angle without asking the technician to do the, what I'm talking about, the helicopter, turn a little bit more, go to the exact same location. You can use that clip to get the precision that you need in a very timely fashion. And even though that clip is expensive, in that circumstance, it will pay dividends, I think.
It's a wonderful comment. Dr. Raju, can we do one more case, and then we probably will need to adjourn?
Chuck, we are supposed to stop at 5, right?
Yes.
We stop at 5.
But we want more. We always want more, Raju.
You're in a beautiful city, Dallas. You should enjoy Dallas. I can keep on entertaining you for the rest of the night. All right. Are you sure?
I asked the audience, can we get some more Raju? All right, let's get from you, please.
All right. Okay. Before I go further, there are a lot of senior gastroenterologists here, and when we knew the anatomy well. Any perforation in the rectum below the peritoneal deflection, you can manage conservatively. So I just want the fellows to keep that thing in mind. But if you have the resources, like Philip did, it will get the patient out. But if you have your anatomy right, below the peritoneal reflection, if you have a perf, you could manage conservatively and still get the patient out without a problem. I'm not saying that That's the way you should do. That's what we did without getting people into trouble. So, all right. All right, this is, I think we need to see a bleeding case. So, 55-year-old man, he was referred for EMR, and let me show this lesion. All right. And one thing is, I want to keep in mind, there's a little bit of fluid here, and I want you to keep in mind every time you do a case, right? And for the sake of time, I will just move forwards, and we injected. And one of the things that I do when I'm injecting is I'm not injecting multiple sites. I inject one place and get as much lift as possible, and maybe inject another site, and then we resect it. And then after the resection, so after the resection, this is what's happened. So usually these things happen at the end of your day.
Of course.
All right. And so we have all these options, and let me ask the panel, what would they choose? So let's start with Rupa. Rupa.
I think I would call my colleagues, but I would do the EP injection first, and then maybe use a snare cautery.
Okay. Yeah, it's actually, I know, you know, what you shared is very important. When you're doing these cases, especially at the end of the day, I think it is scary when you are the only person left and everybody has gone home, right? And it's good to have these cases done early in the morning when we have backup. All right, Chuck?
You know, for what I've seen of it, it could be an epi and clip kind of thing. There are sometimes, if it's smaller blood vessels, using a forceps, whether with current, it's in the cecum. I'd probably stay away from APC for it. So I'll say, in general terms, you might inject, you're pinching it somehow.
Right. Okay. Jeff?
Well, in this case, I know where the bleeding is coming from, so I would not get too nervous about it, because it's not an upper GI bleeding where you have to worry about aspiration. And so I usually use a cap. So I would use the cap to compress on that area where I just cut and see whether they can slow down. And then I would look to clear that area to see, and then I would have soaked coag on the snare. And then if I can find the blood vessel, a lot of times you can actually slow down the bleeding by clicking on it. Mm-hmm. And then if you find the location, or if you can't see it, when you pour the water in, you can see the blood coming out from the source. And then you can just cauterize it. So that's what I would do first. And if that fails, epi injection, carpet bombing.
Okay. Kim, what would you do?
I would probably also do epi and a clip, just what I'm most comfortable with it. The other key thing is to really try to clear the field as much as possible so that you can identify what is bleeding.
Phil, what would you do?
So I think, you know, that the takeaway from the group is basically, which I'll sum up, is do what is comfortable for you. Like, this is not the time to learn a new technique. This is not the time to learn a new instrument. Do what you are comfortable with. Personally, for me, this is this is not fair. This is an ESD slant. I reach for coagulation forceps. Even before then, I clear the field, which is very important. Make sure that this is not in a gravitationally dependent location, because that'll make your life more difficult. But assuming this is not gravitationally dependent, I would irrigate a little bit of water, figure out exactly where's the pinpoint vessel that the bleeding is coming from, and reach for coagulation forceps with soft coagulation. One thing that I will mention is that this is the next generation Olympus processor, which is not yet available in the US, but is available in Europe and Japan, contains a new feature in addition to MBI. There's a new setting on there called RDI, or red dichromatic imaging. It's a little bit different than MBI. MBI is like a blue light, right? And so RDI is like it's like a red light. And what that does is, under RDI, the color of blood, I don't quite understand the physics behind it. It's kind of weird. But the color of blood kind of gets canceled out and turns into a yellowish hue. And you can actually see the exact point in which the yellow is coming out of the vessel. So, I don't know at what point in the future we're going to get something like that. The U.S. always seems to be behind in terms of these new technologies.
Yeah, I'm glad that you talked about this new concept about RDI. It's worth for people to learn and keep an eye for this. And the problem that I had was I was not able to find the source, and it's pulling up. You see that? And when it is pulling up, for the sake of time, it's important to rotate the patient. And that is a simple trick that you could do whenever you can't locate the source of the bleeding and there's pulling up. If you remember, one of the points that I mentioned is, before we resected, the polyp was there and there was fluid in the cecum in the same level as the same plane as the polyp. And when you see that, and when you end up with the bleeding, you will have a tough time finding the source of the bleeding. And that's what exactly happened, right? I gave AP injection. I couldn't find the source of the bleeding. Like Kim mentioned, right? You better change the position so that you can find the source of the bleeding. So we actually changed the patient's position. And you may wonder, why the heck did you not do that up front? He was a very big guy, and we started doing this case under general anesthesia. And we didn't have, at the end of the day, right? End of the day, you take some shortcuts. And we didn't have a lot of help. And the people who were helping me were not, set to move this big patient. So finally, we had to call for help and get some help, and then move him to the supine position. And following that, basically, we tried to see, right, it is coming from this edge, but I can't see the bleeding source. It's coming from that small edge, and I thought, okay, let me try hot baths and a coag rasper with a soft coagulation, and then I'm trying to grasp. I don't know what I'm trying to grasp, to be honest with you, hoping that I will catch a vessel. But it did not make any difference. And I tried to apply some soft coagulation. You have to keep in mind, this wasn't a cecum, and you'll have more problems if you just blindly cauterize. And the vessel has retracted under the edge. So what we did was, we went ahead and took a clip, and then, knowing where it was coming, I just wanted to apply some tamponade there. I don't want to deploy the clip because there was still a little bit of polyp left that I wanted to clear. So we applied the clip, we didn't deploy, we sat there for 5 minutes, the bleeding basically stopped. I wanted to have a good thrombus to form. And after that, we reopened the clip. And I reopened the clip because I wanted to complete the resection. And we completed the resection. And then we went ahead and did the APC at the edge, because that's what I've been doing for the last 12 years. As part of a protocol, routinely APC all the resection margins, which has actually led to pretty low recurrence, about 3% recurrence after large EMRs. And then I said maybe I should cauterize a vessel. You know, and then and then we close the defect with clips. So I heard one of our colleagues mentioning that when you have like a resolution clip, it has a better rotation. I agree with that. Whenever I'm trying to do a difficult closure and I want to have the fine rotation, I always go for the resolution clip. Again, I don't have any conflicts, but I wanted to say this. Whatever I say, hats off to that engineer who actually built that one-to-one, almost like degree by degree rotation that no other clip actually comes close to this. So I want to just summarize here. I think whenever you're doing a large polyp resection, they tend to have multiple bleeding vessels. You have to be prepared for to manage the bleeding. Think about the polyp position, dependent or not. If you can't find the source of the bleeding, rotate the patient. Think about clip tamponade, and I've used it multiple times. It always helps. And complete the cut. Make sure that you get the job done, and then apply the clips like a approximation. At this point, I want to thank Kim, Rupa, Jeff, Philip, and finally Chuck for this opportunity. You all made the show a beautiful show, and I've learned a lot from you all. I'm sorry I'm sitting in front of a window, so I have too much light on my face.
Dr. Raju, thank you. From your quote, from your CV, I would alter it a little bit. I think both hands and lips from you are holy in your wonderful wisdom and all the take-home points. So thank you so much for your time.
Hope you all have a beautiful evening. And make sure you guys keep a rain check for me and Philip.
All right. Thank you. We are adjourned.